And now we move to the second speaker, Professor Ahmed Abdelmati. Professor Ahmed Abdelmati is the Directory of Child Neurology Chief Section of Epilepsy and Clinical Neurophysiology, Children Mercy Hospital. And actually, Dr. Ahmed is the key person in really upgrading and improving our education, our epilepsy management and epilepsy services in Egypt. He is a very helpful person along many years, virtually and in person. He treats us a lot. And now the floor is yours.
Assalamu alaikum. It's a real honor to be here. Thanks for the organizing committee and thanks for all of you being here. As my computer is starting, I'd like to share a very quick story, personal story, why I'm doing epilepsy. It's actually because of the semiology here. I did my training at Baylor College of Medicine in Houston, and one of the patients that I took care of, actually I'm going to show you her video here in a little bit, she had very interesting type of semiology, which I'll show you here in a minute. She was seen by several epileptologists in Houston, which, again, I know there are some people from GW, but I will argue that Houston still is the hub and the mecca for epilepsy in the United States. They missed it. They couldn't diagnose it right. They really completely called it psychogenic. Patient kept going on for about 6 months on different medications. And one morning, actually, I was running with Eli Mizrahi, who was my mentor at the time. And he taught me the lesson of my lifetime, which is why I'm doing epilepsy, because of that young lady who I'm going to show you how important semiology is. It's not just for the diagnosing, or it's partly because diagnosing epilepsy, yes or not epilepsy. About 40% of patients with epilepsy are going to have non-epileptic events or some other functional neurological disorders, are going to have some conversion, some other movement disorder. So it's super crucial, super important. Remember, what we have now and what we talked about are anti-seizure medications, right? So they have to be used in seizures. There's sometimes overlap that they might be approved in some other things. Like, for example, some of the mood stabilizers. We know that lamotrigine is a good mood stabilizer. We know that carbamazepine also what works as a good mood stabilizer. But we also know that 15% of normal people who will never ever have seizure in their entire life, they can have an abnormal EEG. So when I take those 2 points, it's very important to make sure that I'm really, really diagnosing based on semiology. Semiology is really the beginning. One of the things that I learned from Peter Kellaway, if I got off my seat to start examining the patient or any studies without knowing what the patient has, I'm not going to get the diagnosis. So it really starts with the semiology, really starts with the history. And now we have half of an epilepsy monitoring unit on our cell phones, so families can make those decisions, make those things. So I'm going to do my best. So I have you captives here for about an hour and a half. I'm going to try to do my best to go over the overview of semiology. I have one objective for myself. I don't want anybody here to have a non-responsive spell. I don't want anybody to have an absence seizure, hopefully here. So hopefully I'm going to keep your engagement here. Please stop me, interrupt me. I want this to be very informal. Ask questions in Arabic, in English, in Spanish, a little bit of French because I forgot my French. So, but yeah, just make sure you interact, please. All right. So seizures actually has been described by so many different people, and it's those are actually people that there's some documentation, some history that they did have epilepsy themselves. So it's not a new thing. People try to attempt to describe semiology. Even the ILEE continues to adjust and continues to change the semiology description. So it's an ongoing pattern. It's an ongoing thing. So I'm going to go some very, very basic things. I'm going to go over some more of the more complicated things. So this is more for our junior people. What happens is I have an imbalance between my excitatory postsynaptic potential and my inhibitory postsynaptic potential. And that's what causes seizures. So it depends on where this is happening. It can really, really make the semiology change. In the operating room, and I'll show you a lot of operating room EEG here in a little bit, this is a big conundrum. We're trying to get to the focus of the decreased postsynaptic inhibition or the focus of increased excitatory activity. It can be in the focus, which is exactly where the seizure is coming from, or it can be in the spread zone. So the semiology really helps me a lot to be able to tell, okay, what am I implanting my electrodes? Where exactly am I going after that resection? What am I ablating with my laser machine? So, because otherwise, I'm not going to have good epilepsy surgery outcome. I'm not going to be able to get good outcome of my treatment, or I might actually even misdiagnose my patient. So even if I'm not going after epilepsy surgery, in a lot of cases, they might not be epilepsy surgery candidates. They might not be RNS candidates. They might not be DBS candidates, but still, I will be able to diagnose and I'll be able to better prognose. So I don't keep just adjusting medication based on EEG and so on and so forth. All right. So this is the very first description of any semiology in epilepsy, and this is the it's known as the Akkadian clay, or Muhammad ibn Abdullah al-Aqadi. He's actually the one that described it, and it's a Greek. It was found in one of the Egyptian tombs. As we know, when the Greeks entered Egypt, they defaced and changed a lot of the temples and added their own signature to it. So that was one of the clays describing the first semiology. So what you can tell, I don't read this, of course. I don't read Greek. I can't read, but this is the whole ILE, whatever it was called back then, classification of epilepsy in that little thing here. Then went on to the European Dark Ages, when they thought, you know what, epilepsy is the demon, epilepsy is evil, and they actually used to cut people's limbs because of seizures and epilepsy, right? Because I have my left hand is shaking, my left arm is shaking. Easy. Let's cut the left arm. It will never shake again, right? So that's exactly what they did. And they would actually take the blood from people with epilepsy to inject in people because some thought, you know what, they're sacred, they're blessed, and so on and so forth. So a lot of nonsense until later on, Hippocrates and Ibn Sina came to very first time describe that, you know what, epilepsy is not a sacred disease. It's not possessed by the demons. It's actually a brain disorder. And Ibn Sina, in his book Al-Qanun, he actually described that it can be two types: the generalized form and the focal form, formerly known as partial, right? So we'll talk about some terminology that for our junior, please scratch from your terminology, scratch from your vocabulary. There isn't such a thing as partial. There is such a thing as simple. There is such a thing as complex. It has different terms now that we'll talk about. In modern medicine, John Hewlings started for the very first time describing epilepsy, and it's in its more modern form. So, okay, now we know that epilepsy is the name of an occasion sudden, which is the excitatory postsynaptic potential that we talked about that happens. Okay, now this is the fun of epilepsy. This is for those of you who do epilepsy surgery or those of you who do clinical neurophysiology. That's the fun, because we always after the focus. Where's my focus? Where's my focus? Because that can really make a huge difference in my investigations, in my treatment, the choice of my medications, in my drug resistant epilepsy, which is 1 in 3 patients with epilepsy will always have drug resistance, which means drugs will not help their seizures, and I need to look beyond drugs. So if I'm only limited to drugs, then I'm only treating 2/3 of my patients. I still am completely missing 1/3. So to be able to get to that, who's going to benefit from vagus nerve stimulator? Who's going to benefit from responsive nerve stimulation, or RNS? And I know some of those might not be. I know VNS is here. I know DBS is here in Egypt for movement disorder, and I know there's some attempts of implanting the anterior thalamic nucleus for epilepsy. RNS hopefully will come. We'll get here, but it's very important because this is. I'll show you some EEGs and I'll show you some examples that look absolutely generalized, but in fact, it's focal, and patients become completely seizure-free after resection and after surgery. Or is it focal? Is it really, really focal? And where's the focus coming from? And that makes a big difference in my attempt to get things better controlled. Okay, I'm not going to go too much over this slide because it's a very, very busy slide, but it really kind of summarizes a lot of what we're talking about, especially for my friends in the audience, clinical neurophysiologists. You always will have to have the periodic depolarization shift. That's the foundation of any seizure that happens. When I have that hypersynchrony, when I have that spike and slow wave, that will hypersynchronize, will engage more neurons to mount my seizure. That's exactly what happens. Depending on where this is happening, depending where my glutamic acid is being released, or the decreased GABA or gamma aminobutyric acid, that will be my seizure focus. Remember, this can spread. EEG can only look at 6 millimeters of beneath my cortex. It cannot look at the whole thing. So clinical semiology will all the time trump and get over what my EEG might show, especially if it's a deeper focus. If I have an insular, I'll show you some examples with videos. If I have an insular seizure, or if I have a mesial temporal seizure, or if I have a mesial frontal seizure, the semiology is really what's going to guide me, because a lot of times the scalp EEG will take me in a completely different world. On Thursday, we'll talk about at the ILE symposium, we'll talk about some of the paradoxical EEG findings that the seizure might be coming out of one hemisphere, but the EEG is coming out of a completely opposite hemisphere. So it's back to the semiology, 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 semiology. This is really the foundation of epilepsy. Remember, epilepsy is a clinical diagnosis. It is not a neurophysiological diagnosis. There are only few cases that I treat the EEG. I never treat the EEG, with a few exceptions: hypsarrhythmia, subclinical status epilepticus, and ESES or CSWS. This is it. I don't chase my spikes. I don't chase my hyperactivity. I don't chase any of those. So, but to be able to do that, I need to learn my semiology. I need to get it down right. Okay. So those are this is my my ILE, since we're talking at on an ILE co-sponsored symposium here. So I have to, and I'm not going to go over all because you guys know them very well. This is my, those are my different seizure types, and those can be generalized, focal, mixed, or unknown onset. And that's exactly why unknown onset, because it might be obscured. I'm going to show you some videos of some of my Lennox-Gastaut patients and some other paradoxical EEG patients that it's going to be focal on one side, but really showing in the opposite side, and so on and so forth. So, but this those are the different types that we're going to be talking about. Now, there's several classifications. So some of you might be sitting here, might think, why are we talking semiology? I want to learn more about the pathophysiology. Is it FCD type 1, a focal cortical dysplasia type 1, type 2, type 3, 2A, 2B? Could also be electrophysiological or neurophysiological, or could be clinical. But again, clinical is always where it starts. Will always where it starts. We heard the great question by the doctor about patients who stare and they have arrested behavior. Pretty high percent of patients with absence epilepsy will have ADHD on top of it. Is the semiology similar? Is it different? Do I have eyelid myoclonia? What kind of unresponsiveness? So again, back to that clinical semiology, that's going to be very, very important. So again, my symptoms and signs, and that's the clinical semiology. That's going to be my foundation to be able to know the seizure type, and from there we're going to go. And again, I'm not going to go over the seizure types. You know it well. We don't have drop seizures. We don't have partial seizures. We don't have secondary generalization. Those are all terms that we're going to be using the proper terms throughout here. This is for the junior folks in the room. So there's certain terminology that should be completely scratched from our vocabulary. Jerking, fits, things that were really, really old, an older classification. We should be up to date using the proper terminology from what we are having it. The dysrhythmic jerking, the dystonic arrhythmic, I don't know what. So that should completely go away, and we should be using the proper terms on the right hand side. It's even easier. Look at that. One word can make up for a whole sentence. Emotions or appearance of emotions. It's like, what? I can replace it with one word. The jerking arrhythmically or rhythmic jerking and so forth. Okay. I know I talked a lot about videos. We're going to go ahead and see some videos here in a minute. But before I talk about the seizure semiology, I need to weed out. I need to take out what's not seizure. There are a lot of seizure mimickers. And I have to remember that before I start treating my patients. I have to remember that. And if I'm not sure, I always err to the side of normal. If I don't know, if I'm not 100% certain, I always err towards the side of normal. If my EEG is, unless I'm certain that's an abnormality, I'm not calling it. Now, obviously, assuming I know what I'm talking about, I know what I'm doing. And also, same thing for the different types, but we have a lot of types: breath holding spells, several movement disorders, posturing. I remember in my last visit to Egypt, there was a very complicated young man with severe dystonia, and he came on 5 different seizure medications, and all what he has is dystonia. Does not have any seizures. And what we did is we took out all the seizure medications, put him only clonazepam. Significant improvement. I mean, the guy has his basic angle completely fried, so he needs more than just clonazepam. But the point is, there are a lot of mimickers. It's not always going to be just adding seizure medications. As a matter of fact, things can get worse with seizure medicines for several reasons. We heard about the cytochrome system, the CYP450, the 2C19, which can affect and can impact other medications, making their dystonia worse. And by the way, dystonia hates sodium channel blockers. You can really make someone a lot worse with a sodium channel blocker. So if I'm not sure if it's seizure or not, and I put my patient on Name any of the sodium channel blocker, lamotrigine, carbamazepine, oxcarbazepine, any of the sodium channel blockers, and even some of the newer ones, Xcopri. So those all can make my dystonia worse. Gastroesophageal reflux, especially in pediatrics, that's not an uncommon thing. The baby will have pictures very, very similar to spasm. We're going to see some videos here. So point is, I got to make sure that I know I'm diagnosing. And again, some semiologies are going to be very, very confusing, but it's always based on semiology. And again, if I'm not sure, and especially in earlier age, like in the neonatal and then the infantile, epilepsy is not going to trick you. Epilepsy will always have an abnormal EEG. So those are other forms that the parasomnias, a lot of the FNDs are functional neurological disorders, some migraines that might present with hemiplegic migraines or some other confusional migraines. Those can also mimic some of the rage attacks. It's not uncommon. You'll have the psychiatry clinic referring a patient because of drug-resistant epilepsy, and all what it is. They have some underlying psychiatric disorder. Okay, let's go ahead and go over some, and we'll start easy, and we'll get over to some of the more I'm not going to call it complicated, but different semiologies. That's your very common. And by the way, this is a very good and nice and easy test without an EEG. Just hyperventilate a patient for 3 minutes. If I'm not sure, is that an absence? Is that an ADHD? It's not going to be 100%, but it's going to give me a good idea. So that young lady, she has the clear automatism with her hands. She has arrested behavior during hyperventilation. So this is your very common and very typical childhood absence epilepsy. It's easy, it's straightforward. A lot of times, unfortunately, they'll go into around the world. They'll get diagnosed with ADHD. They're not paying attention in the classroom, and they got yelled at by the family, and all what they have is this on their EEG, which is the 3 to 4 hertz frontal dominant generalized high voltage spike and slow wave. And again, for my friends, the EEGers in the room, and I know you know this, the more descriptive my EEG, the better I am. So I teach my fellows, if I close my eyes after I read your sentence, I should see this. Frontal dominant generalized high voltage 3 to 4 hertz spike and slow wave lasting for X number of seconds. So that's how it should be, right? So that's a classical, typical EEG of absence epilepsy. For the sake of time, I'm not going to go over absence epilepsy. You know what absence epilepsy is. You know the incidence, the EEG findings. You know that it can be associated with generalized tonic-clonic. And by the way, do I change therapy? Do I change treatment when I get a generalized tonic-clonic seizure? The answer is no. There's actually a really, really good paper. It's not a new paper. It's actually old from the 80s. Peter Kellaway and Richard Rukavy showed that patients who have absence epilepsy, when they develop generalized tonic-clonic, simply adjusting their monotherapy, if it's ethosuximide or if it's lamotrigine or valproic acid, that in itself is good enough. So I don't need to switch or treat or change my treatment for that. Okay. We're still in the generalized department, and I'm going to show you a couple of generalized, completely different etiology, completely different. Or so it's fragmented, it's brief, it can be asynchronous, so it's not necessarily both at the same time. It can be asynchronous because remember that spread typically. Most, if not all, generalized epilepsies are originating at the thalamus. So depending on the spread, my thalamicortical projections might be a little bit faster on one side than the other. So it might have a little bit of a lag, which is what that young man has a little bit of a lag, a little bit of a asynchrony between the right and the left side. Okay. That young man, complete opposite side. And by the way, this is courtesy of Ilham Mizrahi. This is actually his video. This is the very sudden, quick, generalized myoclonic twitch. So both are myoclonics, right? First one is 100% epileptic or epileptiform. This one is absolutely non-epileptic, right? So they both are myoclonic. I cannot have a generalized seizure in a neonate, especially that's a very young. You can tell by the size of the diaper here. That's a 26-weeker. So it's the same semiology. It's the same exact look. Both are myoclonic. In neonates, I cannot call it epileptic. So I treat it differently. That's an HIE, hypoxic ischemic encephalopathy. I need to put the baby on cooling. I need to do whatever I need to do for HIE. The first one, that's a juvenile myoclonic epilepsy. I need to do different. So semiology can look similar, but the etiology, as I put everything together, excuse me, can look differently. Okay, so myoclonic epilepsy. We'll talk at the next talk about some of the progressive myoclonic epilepsy because I need to be very, very careful about them. And now, for some odd reason, not just in the United States, but also in Egypt and other parts. I was recently in Japan, actually, a couple of weeks ago, and they were reporting that there's a significant increase. They were reporting increase in autonomic epilepsies, which is something that's phenomenal, either because we're knowing how to better test for it, or we have some other reasons that why we're having increase in autonomic epilepsies. I'm sorry, autoimmune epilepsies, and that's what can look and can mimic some of the progressive myoclonic epilepsies. EEG is a little bit different, right? So I have the frontal dominant generalized in this case. That's the juvenile myoclonic epilepsy, the 46 hertz polyspike and slow wave. Again, it's a completely normal background otherwise. Okay, remember we're still in the generalized department. This young man will put it all together. So that's a young man with Lennox-Gastaut syndrome. So he started with having some of the myoclonics, followed by clonic, tonic. Now that's my tonic phase. Then now I'm having clonic on top of the tonic. I'm going to play this video again because it's a really, really good video. I like this video a lot because it summarizes all the general, or most, with a couple of exceptions, the generalized epilepsies. So really the difference between myoclonic, clonic, tonic, and tonic-clonic is the timing, right? So myoclonic is my fastest seizure. That's by far my fastest seizure. The clonic comes next. Spasm, which I'm going to show you next, as far as the timing goes, comes right in between, and that's the frequency, and that's the timing of the discharge or of the movement. So my myoclonic, that's always going to be my fastest. That's going to be very quick, lightning, right? So it happens in no time, and that's exactly how it shows in the EEG. So you see those very high voltage generalized polyspike and slow wave, just a fraction of a second, right? Then comes right after that, as far as the timing, the spasm. We're going to see a video of the spasm here in a second. Then the clonic, that's slower, that's more rhythmic, right? The tonic, that's the longest. That's I'm stuck. Then the tonic clonic, where I start having clonic on top of the tonic. So let me play it one more time. So here are my myoclonics, very quick. Then he goes into tonic. That's a sustained phase. Here's my tonic phase with a back arching and the whole tonic. Now I'm starting to have clonic on top of my tonic. So I'm having now tonic clonic. Now, does that tell me much? All what it tells me is generalized. It doesn't tell me is it generalized thalamic, is it deep and rapid spread. All what it tells me it's generalized. Could this be generalized? Yes. Could this be bilateral tonic clonic? Yes, which was formerly known as some of our young people. We're all young. Some of the junior people. Secondary generalization, right? So we no longer use secondary generalization. It's now called bilateral tonic clonic, right? Okay, so those are typically it's a potassium or calcium channelopathy and so forth. So our famous epileptic spasm. I'm going to show you that young man again when we talk about some of the focal because it looks exactly the same. So look at that, what that young man does. There you go. So it's a phase right between my myoclonic and my clonic, and it can be one or two phases, either my extensor or my flexor. It's unfortunately referred to in the textbooks up until this year. Salam attacks. I hate that term. I don't use it, but that's how it's referred to in textbooks. So that's the only reason I'm mentioning it. Even though I dislike that term, I never teach my fellows and never teach our people to use it. But that's what it's called in the textbooks. But anyway, so that's what it is. It's that flexor or extensor. Sometimes it's mixed. Patients are going to have both the extensor and the flexor, and that's the famous chicken scratch hypsarrhythmia. And just very, very briefly, since we're talking hypsarrhythmia, and I know this is not a lecture of hypsarrhythmia or EEG at all, but hypsarrhythmia has to meet certain criteria. And by the way, most spasms are not associated with hypsarrhythmia. So that picture you don't typically see with epileptic spasms or with infantile spasms, right? But it has to have the one criterion that must be there is the high amplitude. All the other criteria. So Richard Rockaby published the 7 modifications of hypsarrhythmia. All of them, it has to have the high amplitude. If it does not have the high amplitude, and that varies. Some actually literature rates it up to 400, others up to 600. I'm trained by Mizrahi and Callaway, so I'm sticking to the 600 microvolts. That's my cutoff. But that's the most important thing. Another way to know it, if I can read my EEG, anything lower than 20 volts per millimeter, then it's not hypsarrhythmia. If it's so 20 or lower, then it's not hypsarrhythmia. All right, let's move over to some of the focal seizures. And again, focal seizures are very interesting because it depends on, by the time it spreads, what's happening. That's why correlating with EEG helps me out a lot to be able to identify the focus and where it's coming from. So frontal lobe is a whole brain by itself. There's several different semiologies that come from the frontal lobe. Each one of them can be a whole, I promise you, a whole talk by itself, based on the origin, the semiology, the EEG, the workup, the invasive monitoring, and so on and so forth. So let's start with the motor cortex. So notice his right hand. So what he typically describes, that young man, he describes sometimes twitches, and his hand gets stuck. And you see they're doing something. I'm going to tell you what they're doing right in a second. See, they're injecting something in his other arm here. So that's what he does. He's fully awake, fully aware of his surrounding. He's changing the channels on the television, but his arm is in that tonic phase, focal tonic flexion. Then it starts now spreading. Can anyone guess what are they injecting there? I was asking the juniors what yeah, that's exactly what they're doing. So there you go. So that's coming out of, and now he's having bigger spread. So he typically describes, he feels that he cannot move his arm. Sometimes it will have the myoclonic twitch. He actually got in trouble because a couple times he threw the the glass in his hand in his parents' face. Now we're into the bilateral tonic-clonic phase, right? So he's already spread. It crossed the big bridge or the big highway over to the corpus callosum and the anterior and posterior fasciculi. So now it's bilateral tonic-clonic. And that's his EEG. So it starts very nicely over towards the very end. Let's see if I have my. All right. مش مشكلة خلاص مش مشكلة. So I'm gonna point with my cursor here, so you start seeing it. Maybe not. Anyway, you start seeing it by the clock there. That left frontal high voltage initially spike and slow wave, and it spreads very nicely. And see, it spreads bilaterally, but it's clearly more left than right side, more left than right hemisphere. Notice what happened here. So the tech marked the event right here. So that's when the patient started having the event, and that's exactly when they injected the isotope. The EEG doesn't really change until probably around here. That's when I start seeing that semi-rhythmic theta activity and start showing my spikes all the way there. So EEG here wasn't very helpful. It's actually my clinical semiology is really what tells me when the seizure starts, and clinically I can diagnose. So some patients, on Thursday I'm going to show some of the paradoxical. I might start seeing it nothing on the left. I start seeing only on the right side, but I'm guided by my clinical. So clinical will always trump if it starts before the EEG. That's always what's going to trump. That's always what's going to get ahead of that. And obviously, they can have some paresthesia, some numbness. And that young man has this very, very nice focal cortical dysplasia. The reason we did the SPECT for him is just to make sure that he doesn't have any other area. So it was more for confirmation. And again, that's his functional MRI showing, yep, sure enough, his lesion sits right over his motor cortex. So obviously, we cannot do anything about it resectively. We cannot resect it. That's his tractography. So we actually ended up implanting him, and we put an RNS for him. So we are stimulating, and he's completely seizure-free, knowing that it's focal motor cortex. it was implanted with RNS, and that's our ROSA. That's where we doing the further invasive monitoring on the left here, making sure, confirming. You can't see it; it's kind of small, but he does have seizures coming out of his. This thing works though; it's coming right, and this is where his the very top of his electrode. That's exactly where the seizure were coming from, and we put the RNS in, and we put the two electrodes right on top of his motor cortex. Okay, that's another young man. Okay, that video is not. Let me see if I can move it. All right, you're gonna have to wait a little bit. So he's actually a very interesting young man, and he noticed that he's about a minute into the seizure. He's gonna start having some left hand tapping, and it's very rhythmic. And that's another young man. He was actually completely dismissed initially by his pediatrician, but the family kept saying something is wrong, and they kept going. He went to an epilepsy center about probably a couple hours away from us, and they did an EEG, didn't capture anything, but didn't capture an event either, and called it normal and sent the family home. Then he came to our epilepsy monitoring unit, and we were lucky enough that we captured his event. So notice he's going to start having here. Give it a little bit. So notice his left hand. It starts having this posture, and he starts tapping with his left hand right there. That's what he does. So has a little bit of a dystonic posture to his hand, then followed by that left hand tapping. And interestingly, with his left hand tapping, it correlated exactly with those right central high voltage sharp and slow wave discharges. And you can time it exactly, timed, locked in with every single one of those taps. You see those. So it's a clonic theater that's coming right out of his motor strip. And what's interesting, we caught things coming out of his right side as well, and you'll see his right hand here in a second. Look at that. So he has this brief myoclonics. So he was called to have some automatism. He was called to have some PDD, and look at that tapping. And again, he's in the middle of playing with his iPad. So, but very smart parents, like something is wrong. He's not just tapping on his iPad. That's one of his events. And with his EEG, sure enough, he's having those left central, and it's a different frequency. So it's clear it's not a spread, even different morphology, completely different. So you can tell those are totally different seizures coming out of both sides. So for that young man, we did invasive monitoring. Long story short, it was a huge ictal area, so we couldn't really even implant it. So he ended up with a vagus nerve stimulator. He's actually seizure free, but see, the semiology is what helped us to decide how we're going to be doing. The first one, we implanted him with an RNS. This one, the second one, could not do RNS because of how big his area is, and he ended up with a vagus nerve stimulator. Frontal lobe or orbitofrontal. That's one of my personal favorites. I have a special interest, and I have a big research project on frontal lobe epilepsy. So typically, it's not quite aversive head deviation, but it has some of the head deviation. Typically starts with the face and mouth, and later becomes hypermotor. And notice here, he's going to have some fencing later on, right? So he has fencing, he has hypermotor. But how does it start with? It starts with aversive head deviation. That's very, very key for my orbitofrontal. Orbitofrontal it can spread to the SMA area. We'll see a pure SMA seizure here, supplemental motor area, and that's how it starts with fencing. So even though he does fencing, but he doesn't start there. So it spreads. Remember, like when I'm throwing a pebble in a lake, it will spread. It didn't start with the fencing. So it's not an SMA seizure. The seizure spread to the SMA, and that makes all the difference in my treatment, right? So this young man, I'll show you what we did for him. So that's his EG. Again, orbitofrontal. By the time it makes it all the way to the surface, it's going to be obscure, but it's clear. Right or left here? Right? Left? Right. Okay, so of course right. So even though the left side may look a little bit more impressive, but it's most certainly starting more on the right side by not even half a second, right? So it's right hemispheric. But again, there's several orbitofrontal. You're going to see it as bifrontal. Sometimes even looks as if it's generalized. Semiology is what gives it, right? So that's clearly a focal. The guy has that aversive head deviation, the mouth, and also, and it's right hemisphere. So it's the semiology that gave it away, not the EG that gave it away. So again, nocturnal, it has the hypermotor, and so on and so forth. And this is MRI, completely normal. Nothing. We did a PET flare, and it did have a hypometabolism in his right frontal lobe, taking the whole right frontal lobe. For this one, we didn't do stereotactic because of how it is. I really wanted to make sure that we have a good coverage of the whole frontal lobe. So we actually did grids and strips. So we put a big, huge blanket on top, but we also added, I'll show you in a little bit here, strips on his orbitofrontal region. And there you go. So I'll show you exactly where this is coming from. But please notice, this is where his seizures start from. That's on the grid. I'll show you what that correlates to here in a second. So those are my grids. So blue is frequent, red is very frequent, and everything else is completely quiet. And remember, it's frequent. I have my high frequency oscillation, which is a pretty big sign, and I have my inner ictals all coming from the same orbitofrontal. Here's my ictal onset, came exactly from what we wanted it to come, what we thought it would come from the semiology, and that's exactly where his seizures were coming from. All what he left with is that little hole in his brain, and it's completely seizure-free. So we resected the area, completely seizure-free. So again, it was the semiology. If I had relayed on the EEG, it probably would have driven me completely different area, and that's his post-resection. All what he has is that little paucity or little malacia because of the seizure. Okay, now that's a pure SMA. That's actually one of my favorite SMA videos because it's very classic. You really see the seizure starts completely purely SMA. I might have shown this video in previous conferences, but I really like it because it's a very good, very classic picture of an SMA seizure. So she wakes up from sleep, like most frontal lobe seizures that are going to happen mostly in sleep. And look at that. The first thing is I'm fencing. So remember the other young man? He fenced. He did have the figure 4, but that's not how it started. This young lady, it starts as fencing. And usually the fencing for our juniors, the juniors like, oh, حضرتك أستاذنا. So it's typically contralateral to the extended or the flex or the flex arm. I'm hearing flex extended. Juniors, extended. تمام? It's contralateral, and that's exactly what she did. And again, front lobe, you're going to see a lot of this. That's a lot of by the way, I do not use any chloral hydrate at my center. Don't use it. So those are you're going to see muscle artifact, but that's okay. I'd rather that over having the artifact that comes from the chloral hydrate. And again, the fencing at onset. Usually it's drug resistant. Most of them are going to be drug resistant. This is my functional, and it's sure enough coming exactly. And actually, we superimpose the SPECT on top of the functional MRI, and it shows me that it's coming right out of that SMA. Remember, red is exactly where the frequent and the ictal zone, and that's how it's spread. That's my again my scalp EEG with my intracranials, and again she had a very nice resection, and again seizure free. It wasn't the EEG that helped me or helped us. It was the semiology. Semiology is clear SMA semiology. Okay, look at that young man. You can't hear it, but the machine beeps, and with the beep, and that's pretty common. It's actually a rare form of epilepsy, but it's common in frontopolar to have the reflex. And it can be several types of reflex. Can be reading reflex, can be eating reflex, can be sound reflex. So a lot of the, they call it the sunflower syndrome. The juniors, you know what that is? Sunflower syndrome. It's typically in boys and girls who have autism. They'll stand in front of the window and they'll do this. They'll do self-stimming or self-stimulation as if it's like photic stimulation until they have the seizure. And that's another form of reflex epilepsy because it's self-induced or it's induced by something, and that's a frontopolar seizure. And look at the EG. Cannot be more beautiful because it's right at the top. So I see this, and again, sometimes you read in some of the EG reports, blah, 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 and the patient had epileptiform activity. It's like, what does epileptiform activity mean? Is it a spike? Is it a sharp wave? Is it a slow wave? Because his seizure were actually not spike and not a sharp wave. That's a delta slowing, right? So I'm having a slow wave seizure here. So an epileptiform can be anything, can be an alpha, beta, delta, theta, can be anything. It's not necessarily so. So just for our juniors to keep that in mind, I know our seniors here, of course, know this. They teach me that. But for our juniors, make sure that when I'm writing epileptiform activity, I have to specify. Remember, I should be able to imagine exactly the picture you're seeing when I close my eyes after I read your sentence. If I can do that, then I did a good job with my report. If I can, then I need to go back and review them. And that's his focal cortical dysplasia. And actually, that young man, we did laser ablation for him in the MRI suite. It was so superficial. It was so small. It didn't need to go and do a whole epilepsy surgery, big epilepsy surgery. So we did a laser ablation. Oops. Okay, here we go. So we did laser ablation for him. It really, really worked well, completely seizure free with his laser ablation. Okay, I showed you the next video before, but there's a reason I'm showing it again here. So epileptic spasms can absolutely be focal. Actually, we published a couple of papers on that, where this young man has this AVM, and sure enough, with his spasms, that's like we talked. This is not hypsarrhythmia, and he's having those with every spasm. That's all he has. It's a little bit of a left lead, but it's bilateral on the frontal lobe, and we went in. We took it out with monitoring and became seizure free. Okay, another interesting one here. Two more interesting on the frontal lobe. The opercular. So opercular or the dancing seizures. It's typically axial. It's gonna be initially, as you'll see here in a minute, it can really, really rapidly spread. So semiology. So it might look generalized to some of us, but it's the semiology that really gives it away. You'll see here. I don't know if the video is working or not. Yep, it's working. I see mommy, but yep. It's out of sleep, like most, if not all, the frontal lobe. It looks like he's going to put us to sleep with him. So he wakes up, eyes straight up. Look at that. It's axial. It's the dancing. He is dancing, right? So axial. And notice what there's a very, very, and that's why I like this video for the opercular seizures, because it's axial, it's rhythmic, and it's asynchronous. So in other terms, it's going against each other. So it's doing against each other. Now he started becoming focal. So you see the eyes going to the opposite side. Okay. Left to right seizure for our genius. Left, right. So it is actually an EG right. So look at that. So look at that alpha activity that starts at the very onset of the seizure. You don't see the same thing up here. And you see that buzz, the beta buzz, and it becomes all bilateral synchrony. Not generalized, right? We never call this generalized, as you all know, right? So that's a bilateral synchrony. Generalized is for the seizure type. This is for the EG. So it's a right frontal lobe seizure. But again, because it's opercular, by the time it makes it all the way to the scalp, it's going to look something different. But I know it from the semiology. That's why semiology is the king. Semiology is really, really how I should diagnose. Then I can add everything. If my EEG disagrees with the semiology, but I know what I'm talking about in semiology, I'll take the semiology over the EEG. I'm going to do my functional studies. I'm going to do everything else from there. So that's the axial. Sometimes it can be tongue, facial, but it's typically axial, and that's what I showed you is typically the most famous one. Remember at the very beginning, I told you there was a young lady. She's the reason why I'm doing epilepsy. That's the young lady I told you about. Actually, I took it from that's an old. Well, I'm not gonna tell you how many years because you're gonna tell how old I am. But that's about 25-year-old video here from my fellowship time. And remember, I think 3 or 4 epileptologists, really well respectable epileptologists, and not because they're bad. It's because epilepsy it can be pretty challenging. So nobody knows all epilepsy. Nobody knows all epilepsy. So this young lady is humbling because again, 3 really big epileptologists. I'm not going to mention the names. Missed that diagnosis, and it was Eli that said, yeah, you know what, that looks like what you'll see it is. That's her seizure. She has this breakdancing move for those who are as old as I am and remember breakdance from the 80s and 90s. That's what she's doing, that breakdancing move. And she's awake. She's even reaching out to the event marker, to the event button, to press the button to mark an event. She's awake during it, but that's all what she does. She's talking. Symptoms. Now, this this can be confusing because not uncommon. Patients will be referred to the neurology clinic because the patient's 20-year-old had ADHD all his life or her life, has some psychogenic episodes with visual hallucinations and auditory hallucinations for all her life, and somebody decides to get an EEG and oh, there's a temporal sharp and slow waves. Who cares? Who cares? I'm not treating this as epilepsy. I'm not talking about. Now, this is different than somebody who's been completely normal, has been all fine, and they have those episodes, stereotypic recurrent episodes. During that time, during those like 2 or 3 minutes, they're acting like she is, or they're acting with psychiatric. Now I take that seriously, right? So somebody with a history of psychiatric disorders who hasn't, like we agreed, 15% of people will have normal EEG. That percentage is a lot higher in folks with psychiatric disorder, especially with schizophrenia. We all know about the temporal lobe spikes and temporal lobe sharp waves in schizophrenia and some other psychotic disorders. So that's different. So I don't treat those and I don't take those as serious as that young lady who's completely normal and she'll have those episodes that might happen once or twice a week. So that's her SPECT, that's her ictal SPECT, and sure enough, she does have that. I'm sorry, that's her SPECT with the MRI, and you do see that hyperperfusion over that side. And we did her mapping. This young lady, we did her with stereotactic because it was that mesial, and I wanted to cover both sides. You can do it one of 2 ways. You can put an interhemispheric grid that looks at both sides. It's a little bit tricky. Not all surgeons like to do that. Or you can do it with stereotactic, which is what we did here. We'll put stereotactic. I implanted 17 electrodes on both sides, covering both sides, just to make sure it's not coming from the opposite hemisphere. And that's what we looked at. That's implanted electrodes, and you see beautiful seizures. And again, for our neurophysiologists, remember a high frequency oscillation, my burst suppression, my spike slow wave, and my delta rhythm. The strongest of them all is the spike slow wave. So she came with a gold medal, and it spreads. And that's the thing. If I had implanted my grids here and did not implant up here, I would have resected this area, right? So it's the semiology that guided where I put my grids, where I put my depth electrodes. Because remember, it's literally like you're swimming in an open ocean. If you don't know where the island you're going to land on, you can really drown and you can really get in force. So, because it's going to spread. And sure enough, so that's the onset. If we did not implant here, I would have resected this area, which is completely innocent. That's only a spread zone. So what guided where we implant was the semiology. Without the semiology, I would have been completely lost. I don't know where to implant, where to put, where to. Yes, we can do SPECT, we can do PET, we can do all the MAG, all the fancy stuff, but it's back to the semiology. Semiology is what made me implant here. Okay. I gotta speed up because of timing. Okay, this is a frontotemporal insult. So that sense of uprising stomach, feeling nauseous, excessive salivation. That's exactly that stomach uprising epigastric sensation. And again, can go whatever after that. I don't care. Can become bilateral tonic-clonic, can become temporal with head deviation. So for those who attend AES, Hans Lutter, he used to, I don't think he does it anymore. He used to do an epilepsy semiology at American Epilepsy Society, and he loved the things that are the zebras, or a frontal lobe that presents like a temporal lobe, or this. But it's the onset that really helps, and then the EG and all the other stuff can come from there. And again, that's a beautiful. And again, you see it. It's clearly starting a little bit on the right, even though you see this left eye-catching high amplitude, but I start seeing the semi-rhythmic activity more on the right side. So the EG is not super helpful. I'm cheating from the semiology, and I know how to land my EG now. Normal EG, that's her FDG PET. Very nice hypometabolism. And again, same thing. Same young lady with the insular, with the chewing episode, so chewing, some of the epigastric sensation, and the excessive salivation, and so forth. So again, implanted. Those are her implants. I don't know if we have a robot here or not, but we typically implant ours using the robot. We used to spend like at least an hour implanting one of those. Now with the robot, we implant like 17 of them in less than 30 minutes. So it makes it a lot easier. Okay, the easy low-hanging fruit that we all love and we all know very well, it's the temporal lobe. So this one I like, and I know I showed several times before in several conferences, but it's another typical for mesial temporal, right? It's the adversive head deviation. You'll notice the difference between that young man and the frontal that I showed you. So the frontal had head deviation, but it's not as adversive as this one. And again, same thing. They're doing the isotope for the SPECT. And again, it starts, so he had the deja vu, had the sometimes patients are going to have a little bit of auditory or taste change, but that young man had the deja vu, followed by the adversive head deviation, followed by the bilateral tonic-clonic seizures. So this is where he has complete arrested behavior. So does he have absence seizure? Does he have, what's happening? So history, right? So he's completely non-responsive. He stops, but he tells us, you know what? I've been there. I've done that. That's a deja vu. And look at that adversive head deviation. Now it's all the way compared to the other young man of the frontal lobe. It didn't go all the way. Look at that. He's going to break his neck. Then now the bilateral tonic-clonic. It's more clonic actually. Then he's going to go into the tonic phase, tonic on the right side. And it's asymmetric. So he's made it easy on us. Sometimes it's not that asymmetric. It's going to be very, very symmetric, bilateral tonic-clonic. But again, that's the focality and the history really is what gives it. Here's my EEG with that very nice temporal buzz. And again, it's more of a theta. It starts as a theta. So I start having some of the little bit of a delta, then going into the theta. So again, back to epileptiform activity, can be anything. That's his PET. And again, that's with his after his resection, that's what it looks like. Gelastic, common, that's common presentation, but it's an uncommon type of seizure. It's described as satanic laugh. It's typically very different laugh from what the child normally has, or from what the patient normally has. So it's a very satanic, high-pitched laugh. And again, it's typically with hypothalamic hamartoma. However, it can be several. So posterior temporal lobe and mesotemporal lobe can present with gelastic seizures. That's your typical EEG. Actually, that young man had two seizures that are going on at the same time. And again, that's post-treatment. So hypothalamic hamartoma, we no longer do it by resection. It's all by laser ablation. So no matter how big it is, laser ablation really does a really good job treating the hypothalamic hamartomas. Occipital lobe, not very common, but it's rather easy to diagnose just by the history. Typically, those patients are going to describe visual changes. But again, not all visual hallucinations, because most of them are going to be in the psychiatry clinic. Some will be in the epilepsy clinic. But again, it's the history. It's that focal aware, or that aura is what gives it away. That's how the seizure always starts. And it's never, I saw a monster coming, talking to me. It's typically either formed shapes, lights, buzzes of light, those zigzags of light. It's never going to be a scenario. It's never going to be someone came to me and told me to do this. That's typically in the psychiatry department for the occipital. And again, it then can spread anyway. It loves through the posterior fasciculus to go to the opposite side to become temporal. So, and again, that's another. We'll talk about paradoxical EEG, and we're going to talk more about that on Thursday. But again, it's the history that gave it away. It's that visual aura or that visual. And again, that's a beautiful. Well, I shouldn't say beautiful, but it has this buzz on the beta buzz with the polyspike activity on the occipital lobe, then spreads. I'm going to skip this very real quickly, but in neonates can be very different. The EG is very different than the previous one. So that's a delta seizure happening out of the, so again, another occipital lobe seizure, which for some reason, especially with hypoxic ischemic encephalopathy, it's pretty common in neonates. Parietal lobe seizure, it's actually one of the less common ones and typically presents similar in younger babies and younger kids, similar to the motor seizure because they typically feel something. Babies are not going to be able to tell you that I'm feeling something, or I'm feeling paresthesia or sensory. So it starts typically after it spreads to the precentral gyrus, and that's how it looks like. So EEG can be helpful. In older patients, they'll tell you know what, I feel numbness and tingling and paresthesia up my arm. And it's not going to be in a dermatomal distribution, right? So that's how we can figure it out. Is it real? Excuse me. Is it real? Is it psychogenic? And so on and so forth. And that's the MRI of that young man. And okay, I'm going to show just a couple of generalized mimickers because that's important. Not all generalized epilepsy are generalized epilepsy. There's several publications. We actually published 7 patients. Elaine Wiley from Cleveland Clinic published about 7 or 8 patients with absence epilepsy that got treated, quote unquote absence. It wasn't absence, but it really was very typical presentation of absence epilepsy that got treated with epilepsy surgery. So it can look very, very absence-like, if that's even a term. So that young man, he pauses in the middle of hyperventilation, and that's his EEG. Classical. Okay. Its duration is long. Exactly. What else? So it becomes slower. It starts actually at 3 hertz. But what do you think of this? What do you think of that, like half a second preceding activity, right? So it's a bilateral synchrony, but it really bilateral synchronizes very quickly, and that was the telling sign. So the kid presented, he came to my clinic because he was failing ethosuximide, valproate, and lamotrigine. He's like, okay, well, let's see ketogenic diet or vagus nerve stimulator. I admit him to the epilepsy monitoring unit. He's like, wait a minute, this is not generalized. That's focal with bilateral synchrony. Yeah, but it's very rapid bilateral synchrony. And sure enough, we actually, after doing the PET was normal, SPECT was normal, everything was normal. We ended up actually doing a pretty large implantation, and sure enough, he did have seizures coming right out of his postcentral gyrus and resected. Yeah, that's an ECOG. Yeah, well, yeah. So that's an invasive stereotactic EEG. So I have here those are 1, 2, 3, 4, 5, 6, 7, 12 depth electrodes. Yeah, stereotactic. Yeah. No. Those are stereotactic. So you see, yeah. So anyway, so he ended up having resection, and his absence, which was not absence, is completely cured. So there'll always be some mimickers, things that will look like a generalized seizure. So those are always I got to be careful of, right? So I got to be careful of the mimickers that are non-epileptic altogether, and I got to be careful of the mimickers that are actually focal but presenting as generalized seizure. So I hope nobody is falling asleep on me here. But just to kind of wrap it up, so clinical semiology really is the foundation for my epilepsy diagnosis. I have to stop my, and again, this is for the junior because I know my professors and my seniors, you know this very well. But for the juniors, history. Stop the patient. Tell me where the head went. Tell me which side started. Take a video of it. Don't take what they're saying and just for granted. It's never going to be, because parents or families are always going to tell you his whole body was shaking. Generalized tonic-clonic. No, I gotta stop. I gotta ask him. Tell me what the heads were, and don't give leading questions. Tell me what the eyes were doing. Tell me what the head was doing. Were the arms symmetric? So even if they don't know the answer the first time, you just prompt them. The next seizure, they're going to be able to tell, and we're going to be able to tell, which helps significantly. And again, I always have my families take videos of their so it's really important, especially for my surgical evaluation. It's very, very important. Remember, we talked about some of the nocturnal epilepsy with the autosomal dominant nocturnal epilepsy. So some of my genetic testing is also going to be very important to look at that. And it can guide the treatment. Is this going to be laser ablation? I cannot do laser ablation or resection in the motor cortex, right? Is it going to be a VNS? Is it going to be an RNS? So really is going to be very helpful to do that. So thank you very much, and I'm happy to take any questions. You're welcome. Any questions? Clear as mud? Okay, there's a question in the back.
She's speaking about the last case.
Yeah, this one?
Yes, please.
Okay, well, they switched on me. Can we bring the presentation back, please? Thank you. Okay, this one?
Yes, please. My eyesight is weak, so I just want to know where is the focal onset here.
Okay.
Because I can't see the labels of the channels.
So this is my left, right. Okay? So if you notice here, there's a lag of not more than probably 400 milliseconds, where you do see a leading high voltage frontal spike and slow wave before it becomes completely generalized. So when I look at this side compared to this, or I look at both those two sides, there is a leading beta buzz with a high voltage spike on the right side that precedes that generalized, or that seemingly generalized, which is a bilateral synchronous high voltage spike and wave.
Thank you.
You're welcome. تفضل الله يبارك فيك ربنا يبارك فيك جزاكم الله خير ربنا يبارك فيك.
My question is general. The last classification, 2017, it adds the comorbidities, from seizure to epilepsy syndrome, and the etiologies. This is very good. But do you think did it add value?
Yeah, I think it adds value from an ideologic standpoint, because of I will be treating my genetic and genomic epilepsies different than my structural epilepsies, and I will certainly be treating my syndromic epilepsies differently than my non-syndromic epilepsies. It's not probably going to add much value for the non-drug resistant epilepsy, but for the drug resistant epilepsy, I believe it added a lot of value there. Yes.
Some terms are so confusing for me, like focal myclonus.
Yeah.
Did you see it a lot?
Yes. Yeah. So focal myclonus is typically going to be more in the neonatal age or the really younger age. Focal myclonus in older, I'm going to show in the epileptic encephalopathies, epilepsy partialis continua. It can absolutely be focal myclonus, right? So the patient is going to be having this focal myclonus. So it's very rare, but it helps better differentiate it so that when I'm referring my patient to you, it's a common language. We're following the same terminology. So that's what adds it. You know what's interesting? Patrick Kwan. And so he's one of the main lead authors. He's in Melbourne, Australia, right?
Yeah.
So and I shared this before, about probably 6 or 7 months ago.
Interested in the first seizure.
Right.
His main topic.
Right. But what's interesting? So he actually invited me to give a talk at Melbourne University about 6 or 8 months ago. So anyway, he's using the very old terms himself.
Up to this
yes, he's still
really?
using the. It's Patrick, you gotta move on because you've already.
Focal, partial, focal.
Yeah. So Jackie French, her most recent paper, she's still talking complex partial secondary generalization. So we know what it means, but especially I think for the juniors as they're learning and as they're getting more acquainted, I'm a stickler to the proper terminology.
Yeah. Most of the epilepsiologists are sticky to the 2010 classification.
Yes, until it changes.
It is very satisfying.
Until it changes. You know, some terms are now becoming offending. The term moron and the term imbecile. Those are medical terms that used to be used in the 60s and the 50s.
Yeah.
Now the term mental retardation is very offensive, so we never use it anymore, right? So we use cognitive disability. So the terms keep changing because of that social stigma and because of that somebody who is gonna make it not as good. I personally like the older classification, to be honest with you, but I have to stick to the newer one.
Thank you.
You're welcome.
Thank you.
Well,
Dr. Ahmed, some EEGs show consistent focal discharge apart from generalized bilateral synchronous discharge. What about EEG interpretation and the clinical significance of these findings?
Great question. So I don't have those examples, but I've shown them before in previous visits to Egypt. So how to differentiate between focal with bilateral synchrony from generalized EEG, right? So my generalized EEG, if it has focal discharges, if it's actually generalized, it's going to be a fragment, right? So any fragment, by definition, the morphology will look exactly the same like the rest of my EEG. It's exactly like I took that one spike and threw it in the left temporal or the right occipital, so it looks exactly the same. And it will not be more on one side than another. So it's going to be equally distributed left and right. That's in generalized epilepsy. In focal epilepsy, it's going to actually look very consistent in one area. That's when I start thinking. So, for example, if I'm reading an EEG and I'm seeing right temporal, right temporal, right temporal, right temporal, right temporal, then generalized, I gotta ask myself, that's most likely a secondary bilateral synchrony. It is not a generalized with a temporal lobe seizure. So that's that. Now, in Lennox-Gastaut patients, they're gonna have both, right? So Lennox-Gastaut, but the morphology will be very different. If I look at the EEG, because again, it's coming from a different source. So back to our basics. That's why I showed at the beginning, the PDS, the periodic depolarization, that's the basis of everything that I do neurophysiologically. If my PDS is coming from a different gyrus, it's going to look different in my EEG, right? So for my generalized, it's going to have a morphology, but if it's in addition to that, it's going to be multifocal. And I'll show you some examples when we talk about the epileptic encephalopathies. The morphology, the look of the series is going to be very different. One will be sharp, another one will be spike. The slowing will be different, so it's going to be looking very, very different. So in BECT, formerly known as Zironic, like زي ما اتكلمنا هنحكي بالليس classification with photic stimulation, and that's a bilateral synchrony. You're going to see that generalized or the bilateral synchronous activity that's happening, and that's actually thought to be more of a genetic factor more than it is a neurophysiological factor. So even in those patients, it's a bilateral synchrony because I'm having that focal consistent discharge that's coming out of that central temporal area.
I would like to first. I would like to thank you very much for your presentation. It's an always pleasure to have you here in Egypt, Dr. Ahmed. I have a question about the case of generalization focal with bilateral synchrony that the patient was thought to have an absence. For me, we have a lot of cases that have absence, typical EEG pattern with some focal discharges from there where we have it for some times. In this patient in particular, you suggest that this is a bilateral synchrony for this, the generalization having a focal onset. I think, for me, it's a very long discharge, spike and wave, 3 hertz. Yes, I agree with you that it has a focal onset. In this patient, you suspect this is a bilateral synchrony as he didn't respond to the treatment, or just for the EEG.
No.
And what about the focal onset? The focal onset we can get, as I said, and as of course you know that we can get focal discharges in the absence patients. How can differentiate?
Those are great points and great questions, Doctora. First, you're absolutely right. In absence epilepsy, I can absolutely have some focal activity. It's going to be one of two types of focal activity: either a fragment, which is going to be dispersed all over, or a leading discharge, but it will never be on the same side every single time. So it can be left, right. So if I capture like 5, and those patients, it's easy to capture multiple seizures, right? With absence epilepsy, I just withdraw the medicine or reduce the medication, they're going to have a lot of seizures. So typically in those patients, if I see that leading, and it happens all the time, a little bit of a leading on the right, then the following seizure on the left, right, left. But if it's consistently, excuse me, If it's consistently every single time on the right, no, I start thinking of it as a bilateral synchrony. Now, as far as, sorry?
Reproducible.
Absolutely. So if it's recurrent, so yes, I can have focal onset or a little bit of a seemingly focal onset on my absence, but it will alternate. It's the bilateral alternating pattern. But if it keeps happening every single time on the same side, absolutely, I would start thinking of it as focal. Now, the other part to it is it can be as long as it can be, and it doesn't have to have the focal slowing afterwards. Because all what it did with the network, it started crossing through my fasciculi, my corpus callosum, and it continued to be bilateral, and it ends as well. Because if it's a deeper focus, which is exactly what this patient had, if it's a deeper focus, I'm not going to see that surface after coming focal slowing. The last point, which is about the drug resistant, that's usually one of the signs when because it's not uncommon for most of us, myself included, to start reading this EEG as generalized spike and wave. But as I start having my patient to be drug resistant, that's always a time to revisit my diagnosis. Every drug resistant epilepsy patient, no matter what, because you know what, like we agreed, no one is bigger than epilepsy. Epilepsy is always going to be bigger than us. So if I have a drug resistance, like, you know what, let me go back and read my EEG again. Let me go back and see what am I missing here. Let me go back to my genetics. So you're right. That's always another safety net or another backup thing to make sure that I'm getting the right diagnosis.
Thank you so much.
Okay, move on. شغالين؟
Go ahead.
كله صاحي؟
Go ahead.
تمام. القهوة شغالة ولا لسه؟
شغال.
تمام.
المحاضرة الثانية بتاعته؟
Sometimes you do for recordings, you see something different, especially when they go to sleep.
Absolutely, absolutely. So,
Yeah.
Dr. Hassan is asking a very good question, actually. Does it matter the duration of the recording or the patient state, if they're awake, drowsy, or asleep? And absolutely, he's absolutely correct. He's absolutely right. So I got to make sure it's a sampling. The more I have, the better. I always say that epileptologists are like pathologists. We always want more, right? Pathologists want a bigger specimen, so we always want more and more and more. But if I have enough, and that's why 3 to 5 seizures, typically 5 is best, right? So I need to have 5 seizures to be able to make my mind. I'm not ever going to take a patient to the operating room without 5 seizures, 3 with some exceptions, right? So in this case, to your point, absolutely, I need to make sure that I'm capturing enough, and that usually stay in the epilepsy monitoring for like 2 to 3 days to capture enough seizures to make sure that yes, 100% of those seizures are that. But again, remember, it's part of the diagnosis making, and it's never one thing. It's a combination of several things. The clinical semiology that guides me, the EEG, then I start having a question mark. What's going on? I do my SPECT. My SPECT will tell me, okay, wait a minute. There is a hyperperfusion in this area. I do my PET. It shows me my hypometabolism. So it's never going to be one thing and one thing only. It's a concordance of the data. But once my concordance of data is concorded together, that's when I go to the next step. But great question. All right, so we'll go ahead and shift gears and talk about epileptic encephalopathy. Epileptic encephalopathy, actually, it's a big topic. So I know we have a hard stop at 11:30. So I'm going to do my best to try to cover as best as I can. That's actually my hospital, and what you see in glass up here, that's the Neurological Institute that we have. So anyway, so let's go ahead and start talking about epileptic encephalopathy. It's not easy to cover epileptic encephalopathy in an hour or two. It's a big, but let's try to take a very high level overview of the main approach. I'm going to focus at the end. That's going to be my biggest focus. Treatable or curable epileptic encephalopathies. There are ways to cure certain types of epileptic encephalopathy. The rest, it doesn't matter as much if I call it Otahara and it was supposed to be something else. So, the treatment is pretty much for the most part is going to be the same, except for those few curable epilepsies. Okay, so there's some common features for all epileptic encephalopathies. They all will be drug resistant. They all will have that developmental impairment. They all will have a level of it. And by the way, you notice I use the term impairment, not disorder and not disability, because impairment might not be disorder and might not be disability, right? So just to remember, I have developmental delay up to how old? I can call a patient developmental delayed up to what age? According to American Epilepsy Pediatrics, for those pediatricians in our group. So up to age of 8, and it just recently got pushed to 12. So I cannot say 30-year-old with developmental delay. No, I cannot say that, right? Because delay means the bus will come, but delayed, disabled or disorder, the bus will never come. So past age 12, it's developmental disorder or developmental delay. Anyway, impairment is neither. Impairment just I have some subpar development. So some patients might be getting with an IQ of 90, but they have developmental impairment. They need more work to get the C, or they need more work to finish their homework, and so on and so forth. So they all will have developmental impairment. They will have some delays and disabilities in some cases. They typically have multiple seizure types. Those are all the common features. EEG varies, but all of it will have signs of encephalopathy. And it's in the name, right? Encephalopathy can be several things. It's not an EEG talk, but very briefly, it can be the generalized slowing. It can be the disorganization. It can be the dysrhythmia. It can be several things that tells me this EEG is encephalopathic, right? So it has to have that. And again, the age vary by the etiology. I'm not going to diagnose Dravet syndrome in someone at the age of 30, right? And I'm not going to diagnose a sialidosis at a 2-year-old, at a 2-day-old, and so forth. Okay, let's talk about some types. I might skip over some videos because of the time. That's an epileptic spasm. Young lady. There you go. So that the previous one was a flexor spasm. That one is an extensor spasm, right? So this is a true hypsarrhythmia, which not always the case. And that's West syndrome. And we all know, since we talked a little bit of history, Dr. West actually described it in his own son. It was his own son that he described West syndrome back in the 1840s. Some say 1847, 1842, it doesn't matter. And again, can be the extensor or the flexor type. And all what it is, it's a form of brain irritability. We really don't care much about the spasm itself, but what we care about what it means. It's a severe form of encephalopathy. My brain is on fire. Typically, those patients will stop eating, stop developing, they lose some milestones. Several reasons we'll talk about, but that's the symptom. It can be several reasons. It can be idiopathic, which is good luck because 25% of them will become normal, or can be secondary to several things. Can be structural, can be metabolic, can be genetic, can be several things that can lead to that. The best treatment to date for epileptic spasms is ACTH and vigabatrin by far. And there are a lot of debate. If it's lesional, I'm going to use vigabatrin. If it's a non-lesional, I'm going to use ACTH. Actually, the New England Journal of Medicine paper actually showed that pretty much about the same. The only exception is tuberous sclerosis because the mTOR inhibition, vigabatrin works better. Steroids comes next. Topiramate, valproate, all of that come next. So we all know the Jackie French paper on the Dravet approach, and it lists valproic acid as the #1 treatment. If the patient has spasms, scratch that. It's actually going to be ACTH. So if I have spasms, I treat the spasms. Regardless of the underlying etiology, I'm always treating the spasms. ACTH and vigabatrin, and again, I use vigabatrin at a different dose that I use it for my focal epilepsy. So for my epileptic spasm vigabatrin, 50 milligrams for 3 days, 100 milligrams for 3 days, then 125 to 150 milligrams thereafter, every 3 days, because I have the train is about to crush me, so I need to go very fast. Okay, I'm going to show just one video of myoclonics, but myoclonic is myoclonic, right? So that's a myoclonic seizure, and again, difference between myoclonic and atonic. There isn't drop seizure, by the way, right? So what's a drop seizure? It's any seizure that did or could have made me drop to the floor. What seizure can do that? Any type of seizure except epsilons, right? So atypical epsilons, focal, myoclonic, aton, you name it. And so there is such a thing as drop seizure. Scratch it from your vocabulary, our juniors, right? So that's okay. So let's talk about different myoclonic types, and there are several myoclonic types that are developmental encephalopathy, or epileptic encephalopathy. Some of the most famous one is SEMI, or severe myoclonic epilepsy of infancy, which was first described by Charlotte Dravet, and that's where the name Dravet syndrome comes from. So again, typically, initially, a few things. Normal development. It has to happen usually in the first year of life, for the most part, typically in the first 6 months of life. Some cases, in cases of tuberous sclerosis, can be as early as the first few days of life and so forth. It can be SCN1A, but remember, there's the Dravet syndrome borderland, which is Michael Borderland said, okay, well, you know, we got to expand it to be on the SCN1A, so it can include several other genes. So if I have my fever-associated seizures, it's not a febrile seizure, it's a fever-associated seizure, right? And I have that history with typical myoclonic, and the EG I'm going to show you, I have Dravet syndrome until my SCN1A comes back. And to be honest, given the economics and given the cost of getting SCN1A, do I really need an SCN1A in this case? I will argue, no, there are other resources to spend this money on than to get an SCN1A. In a perfect world, yes. I'd love to get a whole genome sequencing. I'm going to show you some papers that we published on the importance of whole genome sequencing in getting diagnosis. But will it make a difference in my treatment? For the most part, it's clinical data. So I would say, you know what? Depends on the economic status. But if the family cannot afford it, or if it's expensive, I would probably reserve that to some other therapy and academician and so on and so forth. So they all will have several things, and I gotta pay attention. So we heard a beautiful talk earlier about psychiatric association with epilepsy. I personally do not like the term comorbidities because epilepsy is a lot of things, including Dravet syndrome. You're gonna have the hypotonia. It's not a comorbidity. It's part of the syndrome. You're going to have the unsteady gait. You're going to have the GI disturbance and so forth. So I got to treat all of that. And that makes a difference as I'm choosing my therapy as well. Okay. Now, this is my Dravet syndrome. And notice with Dravet syndrome early on, they typically will have a periodic pattern or some form of a suppression, right? So I have my high voltage spike and wave with some electrodecrement or some disrupted or interrupted EEG. So notice the duration of my interruption here. It's typically 2, maybe 3 seconds at the most. Keep that in mind as we look at the Ohtahara syndrome, because that's one of the big differentiators between the two. We know that the treatment, steripental, clobazam, CBD, or Epidiolex, fenfluramine, which is phenomenal. I don't know if we have fenfluramine here in Egypt or not, Fintepla. It's absolutely amazing. Some of the Belgium studies have really shown significant improvement. And obviously, again, everything else after that. The important thing is we avoid the fast phase. So the slow phase are okay, actually. So your cenobamate or Xcopri, it's actually really a good treatment for, it's a sodium channel blocker, but it's a really good treatment for Dravet syndrome. It's my fast phase that I want to stay away from. Okay. So this is with the febrile epilepsy, with febrile seizure plus, or generalized epilepsy with febrile seizure plus. It's somewhat similar to Dravet syndrome, but lighter or less intensity. Typically, again, early on, it can be as late as 6 years of age. Typically, several genes that can do it. Treatment, it's always drug resistant, like we agreed. All of them are going to be drug resistant, but several types of medications. The Ohtahara syndrome, or the EDI, or the early infantile developmental and epileptic encephalopathy. It was initially described by Ohtahara. The biggest thing, it's myoclonic seizure, and that's a video of my multifocal alternating in Ohtahara syndrome. Look at the EG. That's courtesy of Eli Mizrahi. That's his video. That's not mine. Notice the multifocal and the EG is lit up. It's a Christmas tree. It's everywhere. That's typically, and also the other thing which I captured. Look at the duration of the suppression. It's a lot longer, so it can actually reach all the way up to 4 to 5 seconds, and that's a big difference between if I'm doing an EG, somebody with myoclonic. I'm not sure if there was a febrile seizure or not. If I see that long patterns of suppression, I'm more thinking Ohtahara syndrome, which usually happens a little bit earlier. STXBP1 is one of the more common genes for Ohtahara syndrome. It's a little bit older, like 6 months to 12 months. I'm thinking more Dravet syndrome. I get the EEG. If the suppression is dispersed farther apart, I'm thinking Ohtahara syndrome. If it's closer, then I'm thinking Dravet syndrome. Again, several genes. With Ohtahara, it can be any of those. The STXBP1 is typically one of the more common ones. And again, you do a whole lot of testing, neurotransmitters. You got to look at all your tests. We're going to talk about the tests at the very end. We're going to try to put it all together. Okay, myoclonic atonic doza syndrome used to be called astatic myoclonic. It's now myoclonic atonic seizures. That's the only epileptic encephalopathy type that actually initially starts with completely normal development. The EEG is completely normal background with the slow spike, slow wave pattern, or the slow spike, slow wave activity. So that's a young man who has the, typically they got the atonic, they got the myoclonic. Here's the myoclonic. They also get the atonic. And we agreed, there isn't such a thing as negative myoclonus, right? So there's only a myoclonus or atonic. Myoclonus, something throws me to the floor, something throws me forward. Atonic, I got dragged, exactly. I got pulled, or I lose tone, so I drop. And there's a spectrum for both of them. So that's my doza. Some people pronounce it as deuce. Some people pronounce it as doze. Actually, Dr. Doza, actually, that's how they pronounce it themselves. So it's doza syndrome. And here's my generalized polyspike and slow wave. You notice the background, it's completely normal. And that's one of the hallmarks of doza syndrome early on. They later, a lot of them actually up to 50% can develop Lennox-Gastaut. And we'll talk about Lennox-Gastaut here in a minute. But initially, that's one of the differentiators. It's very interesting. We're doing a big genomic study on our doza syndrome patients because it's about the rule of thirds. A third will do really, really well and will outgrow their doza syndrome. A third will require non-pharmacological therapy, typically ketogenic diet, and they do really well with that and become seizure-free. And a third, no matter what you do, they continue to progress towards pretty bad Lennox-Gastaut syndrome. The reason is we don't know. Several examples of different. So again, you notice this nice, very nice looking background. Then all of a sudden I have this high voltage generalized spike and slow wave, and they can and they will have atypical absence. And the reason, by the way, atypical absence is only atypical because of the EEG. There's nothing else atypical about it, right? So it's the slow spike, slow wave, the 1.5 to 2.5 hertz, as opposed to my typical absence, which is 3 to 4 hertz. Okay, this is one of my, not favorite, I say why I really dislike this syndrome the most because I'm yet to see anybody who did well with it. Unfortunately, babies don't make it. That's the malignant migrating epilepsy of infancy. Unfortunately, every kid that I diagnosed with this syndrome didn't make it past their first birthday. So it's a pretty nasty syndrome. And it migrates, it goes left, right, and it's, notice the left lower extremity. Then notice the right, and it's not generalized, right? And it's not bilateral synchrony. It's a different, babies cannot have that kind of bilateral synchrony. So it's asynchronous. It's dancing left and right, left and right. Okay, Lennox-Gastaut. Please, 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 for our juniors. Lennox-Gastaut are three things. More than one seizure type, developmental impairment. That's why I stress on the difference between impairment, disability, and delay. Impairment, and slow spike, slow wave. Now, more than one seizure type, any two seizure types. Remember, it does not have to have myoclonic. It does not have to have atonic. Any two seizure types. My developmental impairment, like I said, Lennox actually, part of his initial, back in the 50s, initial seizures, had patients that had an IQ of 90. So they don't have to have that non-verbal, non-ambulatory, wheelchair-bound. They can be sitting, talking to. Actually, I have some Lennox-Gastaut patients that drive. Third is the slow spike, slow wave. Let's talk about that for a second. 80% of the slow spike, slow wave will go away by the age of 18. So if I did my job right as the pediatric epileptologist, and I caught the slow spike, slow wave, and I handed over to my adult epileptologist, thank you very much, what if I didn't do my job right? Or what if I got the EEG, like Dr. Hassan's good point, the sampling was not long enough to capture the slow spike, slow wave. So even though it's one of the three criteria, it is one of the three criteria, but it's a soft criterion. So if I have more than one seizure type and I have developmental impairment, I'm giving my patient diagnosis of Lennox-Gastaut. And remember, it's not a bad news. It's only what it's going to do. It's going to tell me which medications I can use and what type of therapies and what kind of services they can get. So Lennox-Gastaut is not that bad. Helmet, wheelchair, drooling, nonverbal. No, there are some patients who are perfectly much better than that. Their seizure might happen once every 6 months, once every 3 months. So it's not necessarily by etiology, and it's not necessarily by the frequency of the seizure. So please, for our juniors, I know our professors, our seniors know this very well, but for our juniors, open your spectrum for Lennox-Gastaut, because that's going to really help you get to the non-pharmacological therapy earlier. Please, medication is going to go far beyond that. I need something outside the box. I need something outside the pharmacy. Okay, so again, several medications. Those are the ones that are approved in the United States and so forth. Okay. Okay, we've seen those types of seizures in the previous lecture, right? I start my clonic, then I got clonic, tonic-clonic. The seizure itself doesn't really tell me much other than it's being generalized. That's my EEG. Okay, wait a minute. That's a slow spike, slow wave. I have a slow background, right? So that's bingo. I've got my history, my clonic, my tonic. I've got this. And this patient, by the way, he talks. He speaks. He works at a grocery store. He works as a cashier, so he can get himself around. So it doesn't have to be that wheelchair bound. And obviously that's another seizure. That's a tonic seizure. Why is it not a spasm? There isn't a spasm that's going to last that long, and I don't have that pre-hypersynchrony that I have prior to the electrodecrement. So that's a very long tonic seizure that you can easily tell by just the EEG without even seeing the video. And here's my slow spike, slow wave. So again, I think the doctor asked about the difference between, so here you go. So you look at the generalized, looks very different. Even look at the multifocal. The morphology of it looks very different on the left than it is on the right, and then is in the left side, because it's two different generators. So it has to have different morphology. It will never look the same. So I can call it a multifocal, and it's not a fragmentary burst. Okay, several seizures of the same patient. Okay, atypical absence. This is very important. The reason I put that in particular, because that can be a big game changer for this patient. My GLUT1 transport deficiency early on. And usually those patients, any patient who starts with absence seizures before 4 years of age, that's the first thing that comes to my mind. Is a GLUT1 transport, and it is a GLUT1 transport deficiency until proven otherwise. How do I know that? I can do the gene test. I can do the CSF. If I'm doing the CSF, I have to do a serum level at the same time, glucose level at the same time. If it's less than 2/3, that's when I start making my diagnosis. Okay, that's my atypical absence. And again, it's not your 3 Hz spike and wave. It's clearly much slower than that. And here you go. That's about 1.5 to 2 Hz. That's my atypical absence. And that's another example from another patient. This is not my 3 Hz spike and wave. That's another GLUT1 transport deficiency. Patient is young, under 4 years of age, absence, atypical absence. That's the first thing that comes to mind. And obviously with developmental delay and so forth. Okay. So this is another with an occipital. Oh, by the way, for our juniors, actually, what's this? Yep, Warda. Okay, what's Warda? Another junior. Okay, occipital and marital rhythm delta 2. Okay, all right. So we're the DEE with SWAS, and again, this is where we're sleep activated. Typically, those patients either LKS, Lundy-Kleffner syndrome, or non-Lundy-Kleffner syndrome. They usually will have severe or can have severe developmental, mainly speech disability and delay. They can have some regression. There's several papers, actually, several ways to treat it. Some of the best efficacy is diazepam. It's actually one of the best because it's once at night. It's a long-acting half-life. Sorry? For exactly. Yeah. But I would use it absolutely before valproate. I would use it absolutely before my steroids, absolutely before my IVIG and so forth. Okay. All right. Let's talk about some of the. Let me skip that for the sake of time. Some of the progressive myoclonic epilepsies. That's a big group. They all will have exactly as the name says. It's myoclonic. It's progressive. And it's severe encephalopathy. Depending on the age, if it's going to be sialodosis, if it's a MRF, if it's a Lafora disease, the age can be different, but they can present similar. There's some differences. So Lafora disease will have some of the psychiatric disorders. The the Umbruk-Lumberg. It's going to be more the very severe myoclonic. So it's going to be some specifics about it, but all of them are going to have the myoclonic. All of them will have that worsening of the EEG, and all of them will have that severe disability, and again, behavioral disorders. Again, several examples of that. I'm going to skip over that. It's going to be in the slides. Each disease with its genetic comorbidities and the highlight for it, with the Lafort disease, the sialidosis, NCL, especially with the late infantile type, which really is not late infantile. It typically happens like anywhere between 4 to 12 years of age, or Batten's disease, which can shorten some of the lifespan. Okay, let's talk a little bit about some of the reflex epilepsies. We already showed a few of them. It's typically drug resistant. I gotta make sure that I got on top of it with earlier treatment. Now, any drug resistant epilepsy, and please note this, if you forget everything about this lecture, remember those two things. One, every drug resistant epilepsy, no matter what the etiology is, if I leave it long enough to become drug resistant, it can become epileptic encephalopathy. So it's super important to get ahead of that. I cannot and I should not, and I'm going to argue to say it's not right to continue patients on medicine number 6, 7, 8, 9, the Rolodex. No, I got to stop. Past 3 medications, maybe 4 in some cases. I make sure it's properly dosed, well tolerated, and proper medicine for that type of epilepsy. And it's not non-epileptic event. I got to move out of the pharmacy. Whatever I choose, if it's neuromodulation, if it's ketogenic diet, if it's resective surgery, if it's this dissociative or disconnective surgery like corpus callosotomy, I got to do something, but I cannot stay in the pharmacy. Some of the structural, all those tumors or large pushing tumors. That one in the middle with hemimegalencephaly. With the Rasmussen encephalopathy. The one on the very right, that's with hemimegalencephaly. Again, some structural examples that all will do the same. That's a video of epilepsy partialis continua. Somebody was asking earlier about the focal myoclonus, exactly. So it can be myoclonic, can be clonic, and it's typically focal aware. This video is not playing. Anyway, a patient's awake talking to you, and the arm or the hand is going on in a myoclonic fashion. And it's correlating time locked. By the way, the EPC, not all the time is going to be time locked. This case is time locked. Sometimes in EPC, in epilepsy partialis continuum, the patient is not going to be having that time locked, so it can be lagging. So it does not mean it's non-epileptic. Okay, and that's another one of them. One of my patients actually with focal cortical dysplasia with epilepsy partialis continuum going on. Okay, let me skip to some of the things that we've done. So that's actually I'm going to show you that's interesting. That's a paper that we published back in 2014. And notice what we found back in 2014, and that was with exome sequencing. We were able to get 45% of positive. We did something similar back in 2022 with whole genome sequencing, and now we're getting 89% return on our investment. Now, I gotta think. I gotta put my money where it needs to go. I can do this in Europe. I can do this in Japan. I can do this in the United States. I gotta be mindful. If my economics doesn't allow me, and we're not talking about one of the ones I'm gonna talk about here in a minute, then maybe whole genome sequencing might not be the right thing to do. I will treat exactly like I would, like we talked about. If the family can do it, yes, by all means. And actually, that's getting a lot less expensive, relatively. It's still quite a bit of money to do a whole genome sequencing. So, some of the practical points here. Under 2 years of age, I stay away from valproic acid. I don't want to run into Pol G1. I don't want to run into my mitochondrial disorders. I don't want to run into my metabolic disorders. Febrile seizures under 2 years of age, I'm avoiding all my sodium channel blockers. I don't want to get myself into sodium channelopathies, even if it's not Dravet syndrome. There's several, like we agreed. There's several other things that can be sodium channelopathies. So if I have a preterm baby, that's the work by Kevin Staley from Mass General, Harvard, under 35 weeks, I would rather avoid phenobarbital. phenobarbital will downregulate my glycine receptor under 36 weeks of gestation. So what phenobarbital should do, which is a GABAergic hyperpolarizing medication, it will become actually epileptogenic in those patients because it's downregulating my glycine receptor. So remember glycine, where my chloride channels can go, where my hyperpolarization will go. It's actually doing the very opposite. It will shut down my glycine and my chloride channel. So I gotta avoid it. So levetiracetam is a really good, topiramate is another good first line. And again, then based on my EEG, based on my MRI, rationale polypharmacy, based on mechanism of action. I don't need to switch someone from carbamazepine to oxcarbazepine to Aptium. It's all the same. They're all cousins. So I got to look at the rationale pharmacy, and I got to look at the non-pharmacological therapies as early as I can. I got to look at outside the box, the non-pharmacological therapy. So that's a paper that we published with role of epilepsy surgery and resection in epileptic encephalopathy patients. And those patients are getting either completely seizure-free or significant improvement. So I got to look outside the box. Ketogenic diet, another one we have. There's several papers. I brought some of ours about ketogenic diet in refractory and in epileptic encephalopathy. Vagus nerve stimulator, the ultra rapid, that's actually one of our most recent papers. We just published it back in December of just a couple of months ago. That ultra rapid in some of the absence and some of the myoclonic and some of the refractory epileptic encephalopathy. So I got to move outside the box. I got to move away from my medication. Another paper about our vagus nerve stimulator, the ketogenic diet and vagus nerve. And the point I put this paper here is it can be multiple therapies. I shouldn't stop only at medications. I shouldn't stop only at VNS. If my patient is still having seizures, and a lot of them will, I got to move down that list. I'm almost up. Okay. Here are the real nuggets here from this. Now, I'm not going to go over the biochemistry of it because I've been talking with you now for about an hour and a half. I'm sure you want to get rid of me already. But that's really important. So with the GLUT1 transport deficiency, I have my glucose as my main fill for my brain. I have my transporter that's blocked. I got to do something different. So that's one of the better treated / curable epilepsies if I diagnose it early and if I treat it properly with ketogenic diet. Methyl tetrahydrofolate reductase. Remember, I need methyl tetrahydrofolate reductase for several things. I need my methyl tetrahydrofolate, and I need it to be reduced. So my FAD-H, way back, second year medical school now, to FAD, and I need to give it that extra hydrogen to become my methyl tetrahydrofolate reductase, which will later play a very important role in my GABA production, right? Those who like neurochemistry, that's exactly which will play also a role in my folate. So what happens here is my folate metabolism, it's going to get me to my methyl tetrahydrofolate, then my BH4 to later get to my pyridoxal phosphate, which will help my most important enzyme, which is glutamic acid decarboxylase. I know I lost you. So I need my glutamic acid to become GABA, right? That's how I metabolize it. So I metabolize it with my glutamic acid decarboxylase. That's the most important enzyme. To make that happen, I need my pyridoxal, or I need my pyridoxine, vitamin B6. To make the vitamin B6, I need pyridoxal phosphate. To get that, I need my methyl tetrahydrofolate, so it can get me my my biopterins and can get me my my BH4. Okay, so one is my my GLUT1 transport deficiency. Two is my methyl tetrahydrofolate reductase. If I don't have the resources to test for it, simple. If your patient is drug resistant and you're doing the EEG, go ahead and give them a vitamin B6. Typically 150 milligrams in 50 milligram increments, and see what happens. Folinic acid for my tetrahydrobiopterin patient, not folic acid, folinic acid. Typically I start with 25 milligrams all the way up to 100 milligrams. And that's in my patients. If I'm not going to do the CSF testing, if I'm not going to check for my neurotransmitters, my non-ketotic hyperglycemia, that's easy to check for, and it's also easy to treat, right? I'm not going to go over the chemistry of it. It's there. My tetrahydrobiopterin, we talked about tetrahydrobiopterin, similar treatment. I need my vitamin B6 and I need my folinic acid. My biotinidase. I need my biotinidase. Remember, it's all about that GAD, the glutamic acid decarboxylase. So I need my biotinidase to get me my biotin, which will later get into my my pyridic sulfophosphate, which will help my glutamic acid decarboxylase. You don't have to remember all of that. Please, I know our seniors know this very well, but for our juniors, for your patient who's drug resistant, GLUT1 transport deficiency, think ketogenic diet. Biotinidase deficiency, biotin. Methyltetrahydrofolate reductase deficiency, folinic acid. Cheap, easy, but you can really save the patient. Your non-ketotic hyperglycemia, your sodium benzoate. And again, obviously your pyridic sulfophosphate. If you want to get fancy, we typically do it on EEG. EEG is running, you see ugly EEG, you give the pyridic sulfophosphate, you give the pyridoxine vitamin B6, and the EEG normalizes. It can be delayed response. It can be up to 48 hours. So typically keep the patient for 48 hours at least from there. Last slide. So remember, almost all drug-resistant epilepsies are, almost all epileptic encephalopathies will be drug-resistant. You gotta move out of the pharmacy, and I gotta think of my curable epilepsies. If it's not responding to my medications, what am I missing? Could it be pyridic sulfophosphate? Could it be biotin deficiency? Could it be one of those things that we talked about? Then going over that treatment algorithm we talked about, and again, prognosis really varies by type. I know we're like a few minutes over, and the prayer is about to start, so we can hold the questions until after the prayers, but thank you very much for your attention.